None of the producers have any financial interest in the products or procedures shown. Urrets Zavalia syndrome is a clinical condition first described by Dr. Alberto Urrets Zavalia Jr. in 1963 with wide and rigid pupils following penetrating keratoplasty. In Urrets Zavalia syndrome, patients can have normal intraocular pressure IOP or increased IOP. If there is normal IOP, there is mydriasis, photophobia and glare. Increase in the IOP is due to a closed-angle glaucoma and the treatment is pupilloplasty or any technique of pupilloplasty. Mechanal technique, Siepser's technique, circlage technique or the single-pass 4-throw pupilloplasty. In single-pass 4-throw pupilloplasty, a 9-0 or 10-0 Prolene straight needle suture is passed through the clear cornea and then iris. And from the other side, 26-gauge or 30-gauge needle passes through the paracentesis and then iris. A loop brought out and 4 throws done. This creates the pupilloplasty effect. This has been published in the European Journal of Ophthalmology. Following penetrating keratoplasty, a closed-angle glaucoma can occur due to Urrets Zavalia syndrome as seen in anterior segment OCT. The intraocular pressure is very high with medication not helping. The solution is to open the angles by pulling the iris structure and then suturing the pupil together, thus making the angle from closed to open. We created a nomogram for Urrets Zavalia syndrome. If there is closed angle more than 270 degrees, 6 points traction is done. And if less than 270 degrees, 4 points traction performed. Anterior chamber can be maintained with viscoelastic or fluid through an AC maintainer or a trocar AC maintainer. A 9-0 or 10-0 straight needle Prolene suture is passed through the clear cornea and through the iris. From the opposite end, a 26 or 30 gauge needle is passed through a paracentesis and then through the iris. A single pass is created and the loop brought out through the paracentesis. Subsequently, 4 throws are done, sealing the pupilloplasty. A 4-point or 6-point traction can be done depending on the nomogram. The basic principle here is simple. Pre-op and post-op, the angle has to be opened and the intraocular pressure reduced. Urrets Zavalia syndrome can occur even after a glued IOL. If the patient has only mydriasis, without a closed-angle glaucoma, photophobia and glare are the main symptoms. These patients benefit from pupilloplasty. An endo-illuminator from outside can help in visualization. In Urrets Zavalia syndrome, the patient usually complains of decreased vision, glare and halos. On examination, the pupils are detected to be fixed and dilated that do not respond to either myotics or mydriatics. Following the pupilloplasty, the pupil is brought back to normal size. Single-pass 4-throw pupilloplasty bears a close resemblance to timber hedge knot. The 4-throw holds as T2 is greater than T1. Preoperative examination comprises of recording Snellen's best corrected visual acuity, intraocular pressure measurements with applanation tonometry, gonioscopy to view the angles, and an anterior segment optical coherence tomography. Often surgeons attempt to choose a non-invasive option of fitting a cosmetic contact lens that helps to filter light and prevent the glare. But often, these cases need an additional therapy of control of IOP that occurs due to angle crowding associated with the fallback of the iris tissue into the anterior chamber angle, leading to the formation of peripheral anterior synechia. Performing a surgical pupilloplasty helps to pull the iris tissue by causing mechanical traction and pulling up the iris from the angles. Therefore, viewing and assessment of the anterior chamber angles is extremely important in cases of Urrets Zavalia syndrome. The mechanism of Urrets Zavalia syndrome has not been fully determined and it is probably multifactorial. Most likely, it could be due to ischemia of the iris and acute rise in intraocular pressure. The installation of strong mydriatics brings the iris into contact with the peripheral cornea, which can produce peripheral anterior synechia and thus trigger the scenario. Another hypothesis is the toxic reaction of the iris to topical agents. Subsequently, Urrets Zavalia has been reported in various conditions other than penetrating keratoplasty. It has been reported after trabeculectomy, argon laser peripheral iridoplasty, phakic IOL implantation, DALK, decimate stripping automated endothelial keratoplasty, goniotomy, and also octofluoropropane gas injection. The dilated pupil in Urrets Zavalia syndrome does not respond to pilocarpine, sympatholytic agents, or to alpha-adrenergic blockers. Hence, the treatment is directed towards the symptomatic control of glare and photophobia. In some cases, if the trabecular meshwork is badly damaged, one can treat with trabeculectomy with or without an antimetabolite or glaucoma drainage device. Pupilloplasty approaches the issue at hand by not creating an additional route for drainage, but in fact by reopening the existing drainage route and normalizing outflow mechanics within the eye. Urrets Zavalia syndrome can occur after DALK, and if eye is phakic one can make it pseudophakic and then perform the single-pass 4-throw pupilloplasty. In a case of Urrets Zavalia syndrome, prior to doing single-pass 4-throw pupilloplasty, pupillary stretching is performed at every clock hour, wherein the pupillary edge is pulled with an end-opening forceps with an aim to release the pre-existing peripheral anterior synechia from all quadrants of the angle. Once the iris has been released and is comparatively mobile, pupilloplasty can be performed. Pupilloplasty is a great arsenal in treating patients with Urrets Zavalia syndrome. It can be combined with pre-decimates endothelial keratoplasty or any endothelial keratoplasty technique in patients with failed penetrating keratoplasty and having Urrets Zavalia syndrome. The single-pass 4-throw pupilloplasty followed by pre-decimates endothelial keratoplasty can be performed in the same sitting. Complications that can occur in this procedure are intraocular hemorrhage after iris damage. If the eye is phakic, cataract can form. Iridodialysis and iatrogenic iris damage can occur in atrophic cases. This is just the beginning. A lot needs to be done to ensure the safety and benefits of the procedure in a larger cohort.